Always look on the bright side of life, and always look on the right side of the ventricle, and that's exactly what we're going to do in this chapter. We're going to focus on the forgotten chamber of the heart, the right ventricle, and we'll have a look at different pathologies affecting it in different ways. And that can be either due to acute ischemia or acute pressure overload. And you can have a look at the loop here. This is a patient with acute pulmonary embolism, and I'm sure you can appreciate a severely reduced right ventricular function and a dilated right ventricle. And that's all due to an embolus that got stuck in the pulmonary artery, and if we're lucky we can even manage to visualize it with echo in the right ventricle. Furthermore, we're going to have a look at diseases with genetic or endocrine origin. So if we look at this patient here, you can easily detect a severe tricuspid regurgitation, and it's pretty obvious that there's something abnormal with the tricuspid leaflets. They look pretty stiff to me. This is a patient with carcinoid syndrome. The abnormality is not that easy to detect at the first glance at this patient, but if you have a closer look, you can certainly appreciate that there's something abnormal going on here. This is a patient with arrhythmogenic right ventricular dysplasia. So hang on, because we are going to talk about the echo findings in detail. Acute pressure overload of the right ventricle, as it is the case in acute pulmonary embolism, may lead to a life-threatening but potentially reversible right ventricular failure. And that's why early diagnosis is fundamental. The diagnosis, unfortunately, may be missed because of non-specific clinical presentation. So a high index of suspicion using different validated scores and a thorough risk stratification is crucial. So how often does the right ventricle actually fail? Well, we've got data that signs of global right ventricular dysfunction are present in about a third of patients with non-massive PE. And it needs actually at least moderate-sized PE that you can find a significant deterioration of right ventricular function. So how is that defined? Well, it's actually defined as perfusion defects of more than 25% in VQ scans. On the other hand, perfusion defects of less than 20% are rarely associated with right ventricular failure. Therefore, in the acute setting, the absence of echo signs of right ventricular overload or dysfunction practically exclude a PE as a cause of hemodynamic instability. And have a look at the patient on the top. The main problem is certainly a severely reduced left ventricular function. And that's in contrast to the patient on the bottom. You can clearly see the reduced function of the right ventricle. So if you've got a patient who is not stable enough to be sent for further testing, this finding, taken together with the history, suspicious of pulmonary embolism, might be enough to warrant further aggressive treatment. And let me just give you a brief history of a patient I've seen in our emergency department. It was actually a 22-year-old lady who was admitted in a severe cardiogenic shock. Nobody knew why, and she couldn't talk anymore, and we were really afraid that we were going to have to resuscitate her in a few minutes. But then we performed an echo study, and what we could find was a severely dilated right ventricle with a severely reduced right ventricular function. And taking that together with the history we could take from her parents, that she had increasingly shortness of breath over the last days and some pain in her calf, we were pretty sure about the diagnosis, and we thrombolized her. She recovered quickly, and 1 hour later I took her down to CT scanning, where the diagnosis of pulmonary embolism was confirmed. And on the way she was chatting to me, feeling completely well again. So thrombolytic therapy may be life-saving, but it's limited to patients with pulmonary embolism presenting with cardiogenic shock or persistent arterial hypertension. And in these cases, it is a first-line treatment with very few absolute contraindications. But never forget, routine use in non-high-risk patients is not recommended. What are we actually looking for in echo? Well, this table compares 3 different sets of echo criteria, potentially useful for diagnosing acute PE. First of all, we've got right ventricular overload, with a specificity and sensitivity somewhat around 80%. That's fairly reasonable, but unfortunately, if you look at specificity in patients with known previous cardiorespiratory disease, there's a dramatic drop. So let's have a look whether the 66 sign and the McConnell sign do any better. And indeed they do. If you look at a positive predictive value, that's quite high, even in patients with known previous cardiorespiratory disease. Looking at sensitivity, we'll be really disappointed because it's low, actually very low. It's about 25% in the 66 sign and it's 19% in the McConnell sign. So if we get a negative study, then we cannot exclude an acute pulmonary embolism in this patient. Let's look a bit closer on the echo features just mentioned. Well, first of all, we have to look for signs of right ventricular overload. So check if there is any dilatation of the right ventricle. And as you can see in this patient, it's pretty obvious that the right ventricle is severely dilated. It might be not that obvious in other cases, so it's always good to check for a ratio greater than 1 compared with the left ventricle. Or you can use the parasternal view and look whether the diastolic diameter of the right ventricle is more than 30 millimeters. Furthermore, check for flattening of the interventricular septum during systole. And you can see that nicely here. Another sign would be a shortening of the pulmonary acceleration time. The cutoff value is below 90. Another sign of right ventricular overload is tricuspid insufficiency pressure gradient over 30 in the absence of right ventricular hypertrophy. Well, if you're lucky, you can sometimes even detect the cause of acute right ventricular pressure overload, as in this patient, where the embolus got stuck in the right ventricle. Another feature is the so-called 60-60 sign. So what you have to do is just measure the pulmonary acceleration time and a tricuspid regurgitation gradient and have a look whether they are under 60 milliseconds or under 60 millimeters of mercury. And if that's the case, it reflects a disturbed right ventricular ejection pattern. It has been shown that the right ventricle is unable to generate pressures of more than 50 millimeters in an acute setting. But remember, the 60-60 sign has a high specificity but a very low sensitivity, and the same applies to the McConnell sign. The hypokinesis of the right ventricular midwall was first described by McConnell, who thought it to be specific for PE. But this wall motion abnormality can be observed identically in acute right ventricular infarction. So to differentiate both, additional signs of right ventricular pressure overload, as mentioned above, can be helpful. While the common pathomechanism is thought to be ischemia, a functional one in PE due to transient increase in wall stress, and a necrotic involvement in right ventricular infarction due to mechanical obstruction of the right coronary artery. So sometimes it can be quite tricky to differentiate between acute pulmonary embolism and acute right ventricular infarction, especially as patients can present with similar symptoms and similar ECG. And as we just mentioned, they can even have similar echo findings, so CV Doppler can help. In massive or submassive PE, we expect an elevated right ventricular to right atrial pressure, whereas in right ventricular infarction, the pressure gradient should be normal or low. But it's not only Doppler studies that can help us differentiating between those two conditions. You can also look for thrombi, and it's worthwhile doing so because they are present in 4 to 18% of patients with an acute pulmonary embolism. So have a look at the patient on the left. You can see an embolus here that got stuck in the right atrium. Another patient on the right, where the embolus could be visualized in the right ventricle. In hemodynamic unstable patients, there is a high prevalence of bilateral central pulmonary thromboemboli, and a TE study can confirm the diagnosis. So have a look at this patient here. You can see the right pulmonary artery and a lot of thrombotic material. So if you get a picture like that in a patient with a suspected pulmonary embolism, then the diagnosis is confirmed. Well, certainly, a transesophageal echo is not the first-line diagnostic approach, but think of it in patients who are critically ill and unstable for transport or further testing. What else do we have for diagnosis? Well, a shortening of the pulmonary acceleration time has been shown to be a very sensitive parameter, especially in small PEs. It is furthermore a good predictor of mortality, so have a look at the diagram on the top, and you can clearly see that patients with a shorter pulmonary acceleration time have a worse survival. We have been talking about right ventricular infarction as a differential diagnosis for acute pulmonary embolism, but let's focus on it a bit more. It's mostly associated with inferior MI, and literature says that's the case in 30 to 50%, and the difference matters because it's associated with higher mortality. If you've got inferior MI alone, then mortality rates are estimated about 6%, and that rises up to 30% if inferior MI is complicated by right ventricular infarction. So it's worth looking for it. And you can do that by symptoms and signs, as elevated JVP, especially in combination with clear lung fields and systemic hypotension. And certainly the ECG can help. So have a look at the inferior leads. There is ST elevation in 2, 3 and AVF, clearly indicating acute ST elevation infarct of the inferior wall. And if you have a look at the tracing of the right parasternal V4, then you can clearly see that there is ST elevation here as well, indicating right ventricular involvement. An ECG tracing in the right parasternal V4 is associated with high sensitivity and high specificity, so don't forget about it looking for RV involvement. If we want to know something about prognosis of our patient, then echo can help us. It has been shown that peak systolic velocities measured in the basal segment of the free right ventricular wall are useful indices in the diagnosis and prognosis of patients with right ventricular infarction. If you get annular velocities over or equal to 8 cm per second, then those patients have a significantly better event-free survival rate at 1 year than would have patients with systolic annular velocities under 8 cm per second. Well, there's certainly more to say about RV infarction, but I want to stop for a moment and refer to the chapter Coronary Heart Disease for further information. The right ventricle can be involved as well in dilated cardiomyopathy. And as you can see clearly in this patient here, right ventricular function is severely reduced and the right ventricle is dilated. We don't have actually accurate data how often that's the case, but it doesn't seem to be really rare according to our everyday clinical practice. We even find it in patients with preserved ejection fraction, although usually to a milder degree than seen in those with reduced EF. Reduced RV function is an independent predictor of survival in patients with symptomatic heart failure, and reduced peak systolic tricuspid annular velocity exhibits worse survival. We are not sure about precise cutoff values at the moment, but values around 10 cm per second are currently found in literature. Something I want you to keep in mind is that even aging shows an independent impact on those values, so they certainly need further validation. New techniques like strain analysis of the right ventricle may help identifying patients at risk. So have a look at the strain analysis of the right ventricle in this patient who has got a normal right ventricular function. You can see that the velocities are pretty high and all segments are parallel. opposed to a patient with severely reduced right ventricular function. Even at the first glance you can see that velocities are decreased, and on the other hand, peak systolic velocities occurring at different times in the cardiac cycle. So I think right ventricular strain analysis is a pretty promising method, and it's actually not too difficult to perform. Unfortunately, it's highly dependent on good imaging quality of the right ventricular myocardium, and that's certainly the limitation I can see at the moment. As you have probably noticed, right ventricular function is sometimes quite tricky to assess, and therefore always look for indirect signs of RV dysfunction. Sometimes you can detect spontaneous contrast or dilatation of the inferior vena cava, or a significant tricuspid regurgitation due to tricuspid ring dilatation, as you can see here. The right ventricle can be involved in hypertrophic cardiomyopathy, a disease with increased risk of sudden cardiac death. An echo plays a central role in diagnosis and in follow-up. But we don't have exact epidemiological data on how often the right ventricle is really involved. In general, right ventricular hypertrophy, as you can see in this loop, is a rare finding, and it's due to different pathologies. First thing is make sure that there is true RV hypertrophy, so try to optimize the imaging of the right ventricle, especially of its free wall, by tilting the probe and moving it towards the center. Once you have optimized the imaging of the RV myocardium, the diagnosis is easily made. Deep negative S waves in the right precordial leads of the ECG may give a hint to the presence of RVH. Echo measurements of the RV free wall equal or greater than 6 confirm the diagnosis. So let's have a look how to assess RV hypertrophy. There are several causes of RV hypertrophy, with pulmonary hypertension being the most important and the most frequent one. And you have heard about it in chapter 1 and 2. But there are also other pathologies like Fallot's tetralogy, as you can see on this CT scan, or isolated pulmonic stenosis, as shown in this CV Doppler study, but they are really rare, and the same applies to RV hypertrophy due to an VSD. Masses obstructing the RVOT, like Hodgkin lymphoma, are extremely rare causes. But have a look at this huge mass in a patient with Hodgkin lymphoma, and this mass is compressing the RVOT. But there are also conditions of RVOT compression that do not lead to RVH. Have a look at this loop. This is a patient with a funnel chest, and you can see that the right ventricle is impressed by the sternum and looks really slim on this loop. But let's move on from this anatomic variant to a genetic disorder. Arrhythmogenic right ventricular dysplasia, or ARVD. You've probably heard about it, but let me tell you a few facts, because it's an important cause of malignant ventricular arrhythmias among apparently healthy young subjects. It is characterized by the structural and functional abnormalities of the right ventricle, caused by the replacement of the myocardium by fatty and fibrous tissue. So where can we find that? Well, you can find it in the so-called triangle of dysplasia, and that's in the right ventricular subtricuspid area, the apex, and infundibulum. It's actually an inherited disease and typically inherited as an autosomal dominant trait, with variable penetrance and incomplete expression. There's also an autosomal recessive variant associated with palmoplantar keratosis and woolly hair, and that's named Naxos disease. A few words about prevalence. Well, in the general population, you'll probably find them in 1 out of 2,500 to 1 out of 5,000. Nevertheless, it's dependent on geographic circumstances. For example, in certain regions of Italy, or in Greece, like the mentioned island of Naxos, the prevalence is increased. And it accounts for 5 to 10% of unexplained sudden cardiac death in individuals under the age of 65. It occurs in young adults with a male to female ratio of 2.7 to 1, and it's after hypertrophic heart disease, number one cause of sudden cardiac death in young people. ARVD is associated with malignant arrhythmias. Have a look at the ECG on the left. And you can certainly appreciate that this fast VT is potentially life-threatening. On the right-hand side, you can see a resting ECG, and we can find some clues there that can help with the diagnosis. First of all, T-wave inversions in V1 through V3, which is present in up to 85%. Furthermore, you can find a QRS duration of equal or more than 110 milliseconds in V1 to V3. And last but not least, you can find the epsilon wave. And that's electric potentials after the end of the QRS complex, as indicated by the arrows. And it's a major diagnostic criterion that's found in up to 30% of cases of ARVD. Echo is the initial diagnostic approach in patients suspected of having ARVD. So what can we find? Well, first of all, RV dilatation and hypokinesia. Furthermore, look for isolated dilatation of the RV outflow tract and end diastolic aneurysms. But there are more criteria that you can find, like akinesis-dyskinesis of the infrabasal segment and the RV apex. Furthermore, increased reflectivity of the moderator band and prominent apical trabeculae, and you can both see here quite nicely on this loop. Have a look at the moderator band and the apex, and there's certainly more trabeculae than you would normally expect there. Assessing RV regional function has proved valuable in the evaluation of patients with RVD, and you can find regional wall motion abnormalities in up to 80% of patients. And the most reliable single quantitative echo parameter to detect RV pathology in patients with known ARVD was Doppler-derived strain in the RV free wall. RV contrast angiography is considered the reference standard for the diagnosis of ARVD. It consists of akinetic, dyskinetic areas localized in an anatomic triangle of dysplasia. Still remember what that means? Well, that's the apex, the infundibulum, and the subtricuspid area of the right ventricle. Well, however, due to an invasive technique, X-ray exposure, and the inter-observer variability, this method is not widely used. The same applies to computed tomography, especially because of its high radiation burden. So today, the most widely used investigation for the diagnosis is MRI scanning of the heart. The next pathology I want to discuss with you is carcinoid. Carcinoid tumors are rare neuroendocrine malignancies, and approximately 90% of those are located in the gastrointestinal system. The incidence is quite low, it's said to be 1 out of 75,000, and 50% of those develop carcinoid syndrome, and another 50% of those developing carcinoid syndrome would develop carcinoid heart disease. And that's really important to know, because that makes a prognostic difference. If we look at 3-year mortality data of patients with carcinoid heart disease, the survival rate would be about 31%, whereas carcinoid patients without cardiac involvement have approximately twice the survival rate. So in patients with carcinoid, make sure whether there is cardiac involvement or not, because it makes a difference. So what do we have to look for? Well, it's not metastatic involvement of the carcinoid tumors, but it's fibrous changes of different structures of the heart due to vasoactive substances such as 5-hydroxytryptamine or prostaglandins. And these vasoactive substances affect the heart in a perineoplastic manner. And it's mainly the right heart that's involved, and that's why we're finding right ventricular enlargement in up to 90%, and an abnormal interventricular septum up to 50% of cases. But if you have a look at the loop of the patient with carcinoid syndrome on the right, then the most striking pathology is clearly the severe tricuspid regurgitation, and you can surely appreciate that there's something grossly abnormal with the tricuspid valve leaflets. These seem to be really rigid, and you can see a huge coaptation defect. So what are those vasoactive substances doing? Well, they mainly cause a fibrous reaction that involves not only the valves, as you can see here, but also the heart chambers and sometimes the coronary sinus. Back to the valves. It's not only the leaflets that are involved, as you can see here. They are certainly thickened and are very rigid, but it's also the subvalvular apparatus, including the tendinous cords and papillary muscles. And the fibrous tissue leads to distortion of the valves, and that can cause either stenosis or severe regurgitation, as you can see here. In some cases you will have stenosis and regurgitation. Involvement of the pulmonary valve, especially the combination of pulmonary stenosis and tricuspid regurgitation, worsens prognosis. Calcification is rare and regarded as a negative diagnostic feature. The preferential right heart involvement is most likely related to inactivation of vasoactive substances by the lungs. And in the 5 to 10% of cases with left-sided valvular pathology, one should suspect either extensive liver metastases, bronchial carcinoid, or a patent foramen ovale. The last pathology I want to discuss is endomyocardial fibrosis. And in endomyocardial fibrosis, the right ventricle can be involved as well. As you can see on this CT scan, there is obviously left ventricular involvement, but also extensive fibrous tissue on the endocardium in the right ventricle. Have a look at the echo loop. That's what it looks like. Well, clearly in this patient there is only left ventricular involvement, but I just wanted you to get an idea what you have to look for. It's this hyperechogenic feature on the endocardium that doesn't look normal at all. Endomyocardial fibrosis leads to restriction in filling and can lead to AV valve incompetence. Now let's go briefly through the different pathologies you've heard about. First of all, acute and chronic thromboembolic disease. Have a look at the thrombus that got stuck here in the right ventricle. And remember the signs of acute right ventricular pressure overload, like the McConnell sign and the 60-60 sign. Furthermore, we talked about dilated cardiomyopathy and right ventricular strain analysis being a very valuable method for assessing it. We talked about different causes of right ventricular hypertrophy and pulmonary hypertension being the most important one. We furthermore talked about anatomical variants, like in this patient with funnel chest and right ventricular compression. Went on and talked about genetic disorders, like this patient with arrhythmogenic right ventricular dysplasia, and the different echo features that give you a hint for a diagnosis. You heard about neuroendocrine tumors affecting the right heart. And once again, have a look at this huge coaptation defect. It's really impressive, causing a severe tricuspid regurgitation in this patient. And last but not least, you heard about endomyocardial fibrosis and right ventricular involvement. Well done, you've almost made it. You've heard about pulmonary hypertension and its epidemiology in Chapter 1, got familiar with its assessment in Chapter 2, and finally learned about different pathologies of the right ventricle in Chapter 3. So what we want to do now is just to give you a brief overview about different pathologies leading either to right ventricular pressure overload or right ventricular volume overload, or both. So have a look at that.